It's a new spin-off, but at the same time, this kind of work has been going on for last 2 years. And our first use case really is this home recovery for at-risk orthopedic patients. We started out with a much broader ambition of preventive care. Then we realized we need a very specific use case to do the AI and robotics that really will solve a particular issue. So today I'll just cover, what is this solution we have, orthopedic recovery solution, and share some of the go-to-market, milestones that we have achieved and are looking forward to next, especially with C2SHiP partnership as well, and some long-term vision we have where we're really looking for partners to help us expand the applications for the home robotics. So this use case I'm going to talk about is really about hip and knee surgery replacement and the home recovery part. The surgeries are pretty successful these days. We are talking to surgeons, and it's just amazing how advanced hospital technologies have become for orthopedic. The challenge is always the home, where you're kind of left to the patient and they're kind of trying to figure out, am I doing everything right, and all that, and remotely doctors trying to stay in touch. So the readmission rate is not only high, but quite costly for hospitals, especially under this new evidence, this bundle pay models. And just on this 7.2 billion just for this hip and knee. So hospitals are highly motivated to really understand how they can get better insights and prevent readmissions. And some of the large ones actually are taking more control of the home visits themselves. I've talking to some of the potential partners, and because their brand is on the line, let alone penalties and other kind of impact it has on their doctors and their ranking. So the things we are trying to focus are sort of down to the basics in some ways. How do we ensure in the home, when it's could be 90 days recovery, sometime even longer for frail individuals, how do we make sure that these recovery plans are being complied and there's enough guidance for do's and don'ts and precautions to make sure risky things are not happening, and provide some level of mental social support, and have enough data so when there are these remote telemedicine or tele-rehabilitation calls, there's enough data to really properly provide the intervention. And there's all kinds of assessments which can become quite burdensome for patients, recalling, how was my pain throughout the week, things like these. So how do we automate some of those self-assessments and get early indicator of risk factors to avoid readmission? So these all are kind of, challenging topics by themselves. So what we realized is there are lots of point solutions in the market for each one of these, but you really need some kind of this self-driving super app, if you will, one sort of proactive, coach, if you will, which can guide you through readiness at home, all the way to the transition when you are getting discharged and you gotta get all these checklists and things you're supposed to do at home, and then guiding you recovery at home. So these are the three areas where we kind of look at this one integrated platform and a robot helping. So simple examples on prehab is just, is my home, properly, ready in terms of, sometimes it's the bed height, sometimes it's you get loose rugs, cables, sometimes it's just getting ready so that after surgery, it's going to be convenient for me to move around, things like that. And of course, besides your environmental, then there are physical things you got to sometimes strengthen, maybe the upper body because your knee or hip may not be able to sustain. And so a lot of little things which are very easy to give in a guidebook, but how do you make sure those are happening and there's enough guidance? Same with the rehab, they got to do different exercises. So how do I make sure I'm doing it right? Or if I'm experiencing pain, how do I make sure my therapist knows what was I doing when I was experiencing pain? Was it exercise in the bed or on the chair, or are there alternatives I can do if I cannot do this one? Is there so how can the robot proactively, suggest all these kind of monitoring in real time without me having to carrying, tablet around, or kind of positioning my phone here and there. So, we kind of divide the whole AI part into this observe, understand, and navigate. Three-part. Observations is you're sort of observing all the data. Understanding is where, a lot of the magic happens as far as our AI is concerned. And navigate is really guidance, kind of. And when I talk about observation, we are really observing a lot of your ADLs, your micro behaviors, transitions, even the expressions and sounds. So as much we can understand the person. And, then it goes on an understanding part, collecting the data, organizing it into indexes, and then doing the guidance. So this is one diagram which may kind of put it all together, and I will spend a little bit time on this. So observation here, there are two types. One is this auto sort of multimodal sensing. Your kind of sound, vision, other thing, all that you can collect. But then also there are self-reported. You're kind of every now and then talking to the conversations are also events about what the person is feeling, or maybe anxiety or something. And so all these observations, help us do the middle part, which is the understand. And what's the health state? Which stage are they? Are they at the right stage in their recovery? That's where indexes and a lot of scores come in. And the personal model is just keeps getting better, understanding the person. And then the compliance is where you're kind of constantly looking at, is this working? Is this not working as far as compliance? And then, of course, all this is going into your dynamic guidance and nudging. That's where the robot comes in. Observation, you can put a lot of sensors, devices, but when it comes to real-time guidance and nudging you, we kind of felt this interactive device can really make a difference in making you follow your daily goals. Today I got to do this, this, this. It reminds you, lets you know how you're progressing. And of course, the prehab and rehab plans could be longer, 90 days, but daily goals is really where the robot's job is to kind of keep score and guide you through that. This is another way to look at it. Okay, your behaviors, even, you're not supposed to sit more than an hour at a time. Okay, it's nice if somebody is keeping track and reminding me, hey, time to walk around, and just guiding you through this whole, the loop. So the way, we organize a lot of these behaviors and all are really trying to create these 4 indexes: readiness index, recovery index, readmission, risk index, and just general mobility index, which is your gait. And we looked at a lot of these orthopedic assessment, who's who's, and this patient reported outcomes and all of them. And we started looking, okay, what are the things we can really observe directly without asking the person? So those go into this autonomous passive observation, and things we cannot observe but are critical, those become self-reported questions. And one of the things we are doing with self-reported question is really this, asking them at the moment where it's appropriate, the EMA, ecological momentary assessment. So even with pain, asking them when robot senses the person is possibly experiencing pain and or having difficulty transitioning from one place to another in terms of bed to the floor. And so these are kind of a lot of competing products, but what we realize is they're all addressing really different aspects, not the whole journey. And most of them actually are focusing on that half an hour a day of your ortho exercises, where what we think is what you need is monitoring is your whole, the whole day, especially how your ADLs are progressing. Are you having difficulty going to the, trips to the toilet or getting out of bed? So a lot of ADLs we kind of do. Now the AI part of that is really not new. Even though we have been working on it for a couple of years, this is really happening for last 20 years at UC Irvine. Dr. Ramesh, he's the director of the center. They have a Center for Future Health where a lot of this research on AI has been happening. And in fact, ISO has adopted this as a potential standard for personal health navigation, and a lot of big multinationals in healthcare are involved in it. Dr. Ramesh is part of this venture and really the guiding light for all the AI that we are building. I won't spend too much time on this, but I just want to give you some glimpse of it. This whole, we all hear about this word explainable AI. It really needs just data streams are data streams. How do you convert them into events, very discrete events? And by event, I mean is human understandable events. The person was sitting in the 3 o'clock to 4 o'clock in the lounge and was experiencing pain. So very discrete. They have location, time, duration, all of that. And once you start logging these events and the chronicle of those events, that's what he calls personical, which is a person's chronicle. Then you get a nice pattern. And these work very well when you have a like a recovery period, which could last 90 days. And once you convert these observation into events, then what you can do is this whole field opens up. This event algebra, event calculus, all of that. And then there's so there are a lot of published papers. There are books written by Dr. Ramesh on it. And I just wanted to lay it out there. It's not your regular AI that, okay, let's just vision, just figure out if the person is sitting or standing. It's really converting into micro events, which are then used to understand patterns. So this kind of gives a little bit of the robot capabilities. The key was to put multiple sensors in one device, so you don't have to load the home with all kinds of fixtures. And then understand, of course, since it's a robot and it can move around, you can also understand expressions of the person. And of course, you got ultra sensitive mics. You understand, are they in pain, or certain sounds can tell a good story about what the person may be experiencing. And nudging, the idea is, with the tilt and pan and smile and speaker, you can really make it a little more interactive, so people pay slightly more attention to it in terms of engaging. And so a lot of the robot itself has to learn and get better in terms of getting out of the way, keeping safe distance. So all of these are really part of what this whole branch of robotics behavior trees. Yeah, a lot of this. So we are paying a lot of attention and almost this halo zone around the human so that it never sort of has this chance of bumping in or running into. So then, of course, the AI part, like I was mentioning, quite a bit of work on not just your basic, mobility things, but quite a few others. I will bring up a screen just to give you an example of what kind of behaviors we can able to track. Facial analytics, then a lot of audio analytics also we kind of working on, coughing, sneezing, maybe some other, and tap water running, those kind of things. Actions, let me see. Yeah, that's, if they're kind of bending too much, they're not supposed to, or transitioning is, risky, then right on the spot robot can say, hey, this is really not a good idea of taking these kind of movements. And there are lots of them. I mean, we looked at, when we talked to orthopedic surgeons, there's the industry is very clear to what you should do, shouldn't do, but it's hard to really, comply to all those. And of course, this self-reported, a lot of conversational events. So this is sort of the team, quite a bit of experts, Dr. Atul, he's advising, he's a, head of orthopedic hip department at Cleveland Clinic. He and his team is quite heavily involved. Next week, we're interviewing his, 3 key nurse teams. And then Dr. Jacob, he's kind of on rehabilitation science and some of the other experts. So where we are in our go-to market, what we started to do is, let's just we created one simple device where we can do a lot of basic fall risk assessment. That's kind of you're looking at this left one, a little stick, where we can go to a community center, have people walk around and tell them their fall risk. It's a very simple test we can do. Then we are also doing this, putting some fixed devices in the home, so we don't have to wait for the fully functional robot to refine the AI indexes. Stage 2 is what we are doing now, which is really putting robots in the home, in friendly places, near our lab where the R&D team is. So that way it's not like proper, medical trials, but at least we are testing the technical capabilities of the robot. Stage 3 is what we are in discussion with C2SHiP about, okay, how do we design a proper study, a pilot study where we really test some of the use cases, and do they make a difference in patient outcomes? And of course, after that would be the FDA and the commercial. But stage 3, I think, is a key milestone we are looking forward to this year. Our business model, of course, there's a hardware part for the robot, but the bulk of the model is really on the services, working with hospitals, the rehab, professionals, and piggybacking on their billing systems. There's all kinds of billing codes for orthopedic recovery, especially for the 90 days. And long term, we see the devices helping on the prevention, also post-recovery prevention, which is the step 5. And of course, step 6 is the data. We feel a lot of orthopedic big giant companies and even pharmaceuticals are showing interest about knowing what the behaviors actually happen, whether it's their device implants or whether it's because of the medications or what they want to understand. So these are all kinds of CPT codes. I've broken it down between prehab, transition, rehab, and then all across hospitals, DME, equipment providers, physio, nurses. So we think in the recovery, there's a lot of, and these are just basic lab level, and I'll kind of bring up some demos also later on. The robot is quite functional in the controlled environment, but now the goal is to next really 5 months get it ready for more autonomous home deployment with the patients. Recovery, the readmission is a huge area. It's about 58 billion. We are just tackling the first one right now, which is the hip and knee, but there's all kinds of other use cases. And our long-term, this where sometimes the opportunities when we are talking to people, we're just doing the joint one right now. But people are coming up with, okay, how about stroke? How about cardiac? There's all kinds of recoveries which are risky. And some are even talking about, okay, how do we prevent, frail individuals from going to the hospital in the first place? Unfortunately, prevention wasn't the most attractive starting point. So we had to start with recovery, but our long-term goal is prevention. Even in the chronic situations, how can robot help and guide? So we just see next 2 years, it's going to be mostly hospital to home recovery use cases. And we look at this more like ourselves as this open innovation platform. That's why to me, C2SHiP really platform is great, because we have our specific goal, which is, our current focus, orthopedic recovery. But when we talk to companies, they have other use cases. Sometimes they have AI. They say, okay, can your low robot, can we implement it inside your robot, since we have quite powerful edge computing? Sometimes it's wearable companies. I think Janet mentioned also once, can we integrate our wearable into the robot so it can help with the interaction part? So all of these are possibilities for, partnerships. So this is sort of, in some ways, you can look at it. There's all kinds of devices out there, variables, all of that. The key, what we are doing is really creating data stream into these AI models and then converting them so that we can understand situations which can lead to better intervention. And I think I shared this earlier, that we touch a lot of the topics that C2SHiP is passionate about, discharge, smart devices, medicine visits, home visits, home monitoring, and with the goal of really readmission prediction. So for me, this was the exciting part, that we really have a lot of complementary, mission in terms of where we want to go. Better, tighter connection between hospital and home. Now, there are, of course, our main IP is the AI part, which really, when we started looking at the options to create edge computing and do all these micro, behaviors, you really need a very complex multi-sensor installation, local data server, local computer, and suddenly you have a lot of privacy leaks. And of course, you have a lot of interaction overload. So our motivation for robot was really this very straightforward, creating a single integrating device, always on, always nearby, single point of privacy control, all the audio video processed locally. So we are using the most powerful edge computing from NVIDIA, their massive processing capability, so that we can process everything locally. And of course, situation aware interaction. So this is where, the minute you want deeper care insights, it rubs opposite against data privacy and the user experience. And that's kind of where these two things is, but we are agnostic to, either of the situation. So thanks a lot. And I that's sort of the main presentation. And I was sort of, I asked our team in terms of things, and they have like literally hundreds of little demos. And I was like, okay, how do I, so I'm not going to run them, but I can give you a little bit of, like this is standing, the way they are standing is not safe, or the posture is risky, the way the angles they are doing for somebody with the hip surgery, or knee distance has to be made, so a lot of these subtle things is really where this is knee knocking. So when we are working with these experts, they start telling us all these little things people are not supposed to do. And our question was, well, how is the person supposed to know? And of course, facial analytics, we have a lot of these, pain, and then these are kind of all more transition quality. So if somebody is stumbling, I'm not going to run these because they kind of, take a lot of time. But here we are sort of, if they're having difficulty trying 2-3 times to get up, we can, understand there's some challenge going on, or the time it takes for them, or sit to lie, and many things like these. They're really all kinds of these. So these are kind of those micro behaviors, and of course the robot thing. And so I will stop there. Just really, for me, it's really useful to hear what you guys think about this and have ideas, suggestions.
Wow, that's amazing, Dr. Rashid. Wow, I saw that, what excitement. Actually, behind the scenes, some of my clinical colleagues who were on the call also, they said, wow, that's amazing. This is what we need. I remember that about 2 years ago, I have a chat with one of our colleagues who is a thoracic surgeon that say that, you know what, I'm doing a chest surgery, but patient at home, they need to have this external precaution. That means that when they want to rise from a chair, they need to hug pillow. Otherwise, it can completely dislocate the chest. And he wants to have a solution to guide them, because they said that we have so many failures because of lack of confidence of our patient. And some of them, they have cognitive impairments. As you mentioned, they need to be reminded every time they want to come out of the bed, rise from a chair. They need to be reminded, and your technology would be a great solution. But another technology that, as you know, in the US, we are shifting toward it, and you touch on it, is telemedicine and telerehabilitation. It is huge.
Right.
And VA is one of the leaders in the field. And Impactco VA Houston is a hub for delivering telerehabilitation in Impactco for pulmonary disease. And I'm seeing that Dr. Amir Sharafkhane, who is leading this program at our VA, are also on the call. I would like to go to him and ask Dr. Sharafkhane that, what do you think? Do you see that for veterans, you can prescribe that robot that can be as a companion to guide them how to do correctly those kind of the complex pulmonary rehabilitation for the patient? I don't know, Dr. Sharafan, are you still there? I'm not sure that he's hearing us. Maybe he left. I mean, I make a connection with him, but I have another great surgeon that I'm seeing that he's here is Dr. Matar that asked question that asked Dr. Matar, go ahead and ask your question. And I would like to hear your point of view as a surgeon. What do you see about the application of this technology in PATCOR after bariatric surgery?
Thank you very much, Dr. Najafi and Dr. Rashid. I have to say this is indeed very exciting technology that we're watching here. My question, I'm a clinician, I'm a surgeon, and I operate on patients who are medically complex and who have certain limitations. And so this is very interesting to me. My question relates to how will I as a clinician be receiving feedback from the robot on how my patient is doing, and will it be able to alert me should an emergency take place, for example, a fall, or there's a sudden deterioration in the status of the patient. And then finally, will we have large access to the data that it collects over time and volume so that we can go back and establish best practices for our patients?
Sure. So in terms of data, when we started to talk to, some of the orthopedic surgeons, their challenge was the same, that, they want the data, but not too much, So so we're coming up with these indexes, readmission risk index, recovery index, and we try to kind of almost choose the elements that they really want to track and then convert it into some kind of almost like a chart where they can say, okay, recovery is going according to plan. That way you can maintain a little bit of privacy. And if they want to see some part of the curve which is going down and they want to know what's happening, they can get consent from the patient. Hey, let's talk about this. This doesn't look good, this downward trend. And then the patient can give consent to see more details of what was actually happening. So the data ownership really belongs to the patient. That's sort of the key decision we have made, and everything is based on consent, and the indexes are usually don't have the video and those kind of other sensitive thing. And mostly our doctors love it. They say, yeah, I just want to know, if things are okay, or tell me which of the 10% of the patient I should focus on. And that kind of discussion we are having, with through these interviews. And as far as the overall data, we see the most interesting part is going to be these indexes anyway, because that's where we consolidating the behaviors into numbers. So that our goal is to have these data products which are owned by the patient, but they give consent, and maybe there's a monetization on it and they benefit also. So it's their data, and but they're giving some data available, for research and all, but they control that part. And especially if there's incentive for them, then and many like to contribute towards these kind of causes. So that's a big part of the data strategy. We feel that's missing actually. When we talk to surgeons, they kind of saying, hey, I know everything that is going on, I just don't know what's happening at home. And what are these behaviors and what's causing what. So we feel that that's the unique value we are bringing, really, behavior, data, and patterns.
Dr. Rashid, you ask about data, and I'm seeing that we have a couple of great engineers also on the talk that ask about data. Of course, before asking the question of Dr. Akbari, actually, I would like that maybe after his question, also you touch on the privacy. You mentioned that, for example, you were recording speech, and speech is some things that even when we are using Amazon Alexa, some patient has a concern about it, and the strategy that you have to protect those kind of privacy, that would be great. But Dr. Akbari asked that where the information that is gathered by the robot be stored. And
right.
These important questions impacting
sure.
HIPAA.
So the audio and video never leaves the robot. So we process it. That's why we have the powerful, this NVIDIA edge processing compute, which I think itself is quite innovation, because anytime you put cameras, you have to put it somewhere else in the cloud. So we are able to process right there. And the indexes go into, right now we are using Microsoft Azure cloud platform. So indexes, those kind of things, longitudinal data, it goes into the cloud. And within the cloud, there are these private data vaults. So each patient has their own vault, which is, so even the cloud data is not just all bundled together. It's each personal model is separate. So our whole patient engagement, we call N equal to 1. It's not population based, it's individual based. And that's really what that UCI 20-year research has been going on, personal health navigation.
Great. I'm seeing that Dr. Sawyer, you're raising your hands, and you're a clinician as well. So I'm guessing that you may also elaborate on this, and please ask your question as well. You're mute, Dr. Anor.
Thank you for the great talk. And I'm an orthopedist. I was previously a physical therapist and did home physical therapy. And as a physician, I still go into my patients' homes because that's the only way I can really understand how they're doing and what their needs are. So I still do some house calls. Fortunately, with Zoom now and telemedicine, I've got more insights into that. But I want to congratulate you, first of all, on a counter movement to the point solutions that we're bombarded with in orthopedics. And I really appreciate that concept. I'd be happy to provide some advising or, informally, if nothing else, to diversify your team, because I did look at your team slide and I think we need to round it out a little bit with
yes. No,
diversity.
We would love that. That is
but
wonderful.
I think I could add some concepts. One is, I think what's really important is when you get to the implementation trial stage, which is where you are, not only is it going to be user experience, but you're going to have to define where do you need personnel, because we need to keep innovating in personnel, process, and technology. And the technology alone isn't going to solve this. And I know you know that, but that's going to be one of the important things to look at in implementation. Where do you also need either family members or the home healthcare person or the tele rehab? Where do you need personnel still? Because it looks like a fantastic solution, but in our experience, that's going to still be a factor. The other thing is just the cost. So doing, along with your R&D, doing health economics models that makes sense, because some people will say, why not an integrated camera system with AI, which there are many of those companies, and I think you could intersect with them, and I'd like to talk to you about that. But look at a tiered model in terms of complexity and cost, so you could still provide the great actionable insights that you're offering, but at times a person may not afford or even have room for a movable robot in their home. So a tiered model, I think, would be really interesting to look at, since I've been off the grid more than on the grid in Northern California since New Year's because of our storms. But when the power goes out, you still want the patient to have some sort of ability to function. So I'm just thinking of different things. I know you've thought of all of them. And as I said, I don't want to take up the entire Q&A because I could talk to you for about 4 hours just learning more about what you're doing. I love what you're doing. I really do. And I'd love to see if, and also see if you're interested in implementation trial partners. We'd certainly be interested.
No, definitely. That is really the whole, no, we'd love to have a chat with you more, and our team can also have a little more discussion with you. And that's the whole idea with C2SHiP, partnership.
That's what this meeting is so great. Really... Bijan was afraid to call on me, so I'm going to stop here because I really appreciate this.
This is exactly the point. Having a point of view from different disciplines, great. Actually, your orthopedic surgery that you can provide more insight.
By the way, Bijan, if there was a woman or man grown in the laboratory designed to help on this, it would be Professor Sawyer. I think everything in her background prepares her for this.
That's really great. No, I can.
That's so kind of you. I'm really passionate about distributed care, and you are delivering on it.
Listen, Einar, buckle up, because this is, I think, all of us as well. I also, Hugh, I'm sorry about this, Bijan, but we would love, and when I say love, I mean love, to implement this at 2 of the rehab hospitals at which we work. We work at the National Center for Rehabilitation at Rancho Los Amigos, and where Jackie Perry got her start, Einar, and then also at Casa Colina, which is a private, really world-class facility. We have both of those kind of on our team. One's private, one's public, but this is perfect for extending stuff on the prehab and the rehab. And this is what we've been dreaming about, ever since we first saw some of the ideas from Cyberdyne coming out of Japan 15 years ago, 12, 15 years ago in nursing homes for post-CVA patients, just stimulating their quads to get them to stand up and move. And Sean knows what I'm talking about. I just about, when I first saw that, but I think it's ready now. And I think the business model you're thinking about may be ready. I'm going to shut up now.
And David, I was just going to piggyback really kind of assertively here, but your interfacility model is very important. So there are lower acuity level centers, as you've described. Rehab's great, but there are others where I think this could actually function well in facilities, in addition to thinking about the home model.
Exactly. This is a step down. So you have a step down in hospital idea, right? But then you also have a step down in staff. Right. The reason that this has that Japan is so far ahead of us is not because there are more intelligent people in Japan, although there are a lot of intelligent people in Japan. It's because demography is destined, and they have an inverted population curve, and it has driven this. By the way, you're in Shanghai. That's going to happen in Shanghai in 30 years. Big time. India just caught up yesterday. Formally with China because of the one child model. There's 1.4 billion. But that's what's driving this, and it's what's going to drive all this innovation. And this is what is super exciting. But I could imagine it substituting for staffing that is breaking their back literally and figuratively every day. Not just RNs, but LVNs, med techs, and folks that are really just, it's backbreaking.
Right. Our really first goal is really to complement the care team, the nurses, the rehab, the doctor, because that's where we see the biggest impact making in the short term. Just take care of a lot of the routine. So before the visit, we have really prepared all the reports. So somebody comes in, they know exactly what the week exercises were, where were the issues, where were they struggling. And same with the telemedicine. So it's really doing these little things to just, and not put the burden on the patient. That's unfortunately the flip side, where everybody wants data and report, and the patient is there filling out these survey forms. So kind of just remove the burden of chores from the system with things which, but definitely not, we're not even thinking about replacing anybody, honestly, because the more we talk to experts, nurses, the rehab specialists, there's just nothing, we can never touch that space. And our goal is that these medical staff recommend this to certain high-risk patients. They say, hey, this is great. You need a reset. Next 90 days, you'll be doing a lot of things. Here is a device that can help you keep us in touch. That kind of is really a sweet spot.
So this is great discussion. I agree with Dr. Armstrong. Los Amigos, Ranchos Los Amigos is one of the great places, as was nursing home. I talked with some of the leadership of their nursing home. They have a significant shortage of staff. So anything that can help and gather together, that'd be great. So next is Marge asked on sensors, on robots. Go ahead, Marge. Ask your question.
Well, I was thinking about this too, with regards to the biggest challenges that you see. So what you're talking about in putting sensors on a robot and have the robot in the home moving around so that it gets close enough to the patient to be able to make intelligent assessments about what they're doing. So I wanted you to say a little bit more about what sensors are on the robot now, and what do you see as the biggest challenges?
So we, right now we have just the basic audio, video kind of thing. Make sure we have high quality, camera, high precision, this ultra sensitive mic, so we can pick up sound, not just human, also other things. Really tap running in the flush, sound of the flush going, or things like these. And then we have the smell sensor. So just pick up some basic odors, which kind of go along. And so it's kind of these kind of very basic sort of thing. But there are some other things, micromillimeter sensors, all that the team is looking at. But we're starting with really, let's get these basic things, audio, video, smell. It's kind of like, we look at it like the 5 senses of human, and how can you start to get closer and closer and integrate the senses. It's very easy to put sensors separately and act on them, but to connect them, collect the data and make sense of it locally on the edge. The thing I haven't mentioned is that every time we develop an AI model, it takes us a month to compress it so it can run locally in the belly of the robot. So our goal is that eventually all the AI models really, right now, sometime because just time issue, we got to run the AI model in the cloud, and then suddenly your data is exposed. But once you get to a point where all your AI is running locally, you don't need the cloud, so it's like a totally personal device and nothing leaves the robot,
It's great. So I know that you're running time, but if you can stay a couple more minutes to
Sure.
address the question, that'd be great. So next is Dr. David Klonoff. I know that he's working with many companies in the Internet of Things and also smart home, wearable technology, and he's an amazing clinician as well. Dr. Klonoff, go ahead and ask your question.
I really like what you're doing. I see the paradigm we've talked about, the Internet of Things, Internet of Medical Things. This is really the Internet of medical people. The people become what's being sensed. But people are harder to work with than inanimate objects. So my advice would be, show the role of the caregivers in your slide. It looked to me as if you've got robots running around and doing everything, and I didn't see the caregivers. But we're doing a study at my hospital, and we're finding that when people go home, they are really sick and confused, and they have a lot of trouble complying with anything. The picture that we sometimes have in this organization and others is that these are pretty normal people just waiting for help. They're not. They're confused and tired, and they don't even want to engage. So I hope you include that perspective. And the only way to get past this is to include some humans in, and Dr. Sawyer mentioned that, and it's so needed. So, but I think that it'll show that you have a better handle on your customer if you can put the people in. You said you want these tools to be an aid to the people. Yes. So show the people in there and explain what the people will be doing and how your device will help them. That's my advice.
No, that's great. We will show them, but honestly, that is the center of everything we are doing, actually, the care team. But you're right, we have to show it a little bit, more vividly in the presentation. Good, thanks.
It's amazing discussion. Maybe we can conclude with the last question. I know that Dr. Sawyer, go ahead, Dr. Sawyer.
Finally, I just wanted to completely salute what you just said, because I think there's a field around the assistive robot rather than the replacing robot. And I think looking at this as an assistive robot, I think is a really important step.
I echo that. It's very important. So the last question from Dr. Akbari actually is an important question. It's about liability. And I remember that I visited some of the nursing home that was very luxury nursing home in Houston, just open up with the rent of over $4,000 per month, but was very tiny space. And there is not much room for robots to navigate there. And then how it can cause, for example, the risk of falling and creating obstacles and maybe other liability issue that we need to consider. You're talking about, for example, in the absence of electricity. Of course, I know that maybe the robot find a way to recharge it, maybe that battery backup, but how do you think about this liability issue?
I think there will be a lot of challenges. So I see a little bit of us going through what companies like Tesla go through, when they started autonomous everywhere. What happens if it crashes? What happens somebody, there are a lot of those challenges, but and we have spent a lot of time, and then eventually we realize we don't even know it will work or it will make a difference in somebody's life. So then we said, okay, let's park these topics, for post-trial. And so can we show that having an interactive, engaging robot makes a difference in patient outcomes and recovery? If yes, then those other technical challenges are, let's spend millions solving them. But if we don't do the first one, then really, so that's kind of where the team is. And we have thought a lot about those, by the way, but those are tough challenges. And but there are a lot of smart experts who are there to help us. So we kind of being very realistic in really, let's do quick win the orthopedic industry, the home care industry, show them these other problems are worth solving. And privacy is right next to it, safety. Those are the two big ones that, we are just scratching the surface on both of them, actually.
Thank you so much. I really appreciate it. There was a couple of very nice comments that came about your comment about Tesla. So that it's very interesting. But
something just small, sorry, one last thing I want to say, that one of the things we are trying to do with human aware navigation is actually minimize the movements. So it's going to move around a lot first week, but after a while it will learn that, around 3 o'clock, the person lounges around in the living room for 3 hours. So why don't I go there 10 minutes early and just stay out of the way, almost in the background, and predict. And that's where a lot of this personal model is going to come in. So actually our goal is that less and less movement over time, because it knows the daily life routines. And there's a whole, LiDAR, we are creating a halo bubble around the human. So we always maintain, even if there's an empty space between there, we don't enter, that's the whole bubble space. So there are basic things we are doing, but eventually we realize people don't want robot to take over the apartment. They want to be the one moving around. So the robot should more like, like a nice puppy, get to the next destination before, rather than running between the legs. So we're doing a lot of this human aware navigation. I didn't talk about that. That's a big part of it.
It's very important. Actually, you touch on very important clinical assessment that's called life space. That to look at that how patient recover post-hospital discharge. Actually, they look at that how many rooms in their home they are interacting with, and whether the life space exceeded from bed to bathroom that for patient is happening, whether they're going to other spaces as well as out of home. So it's amazing. I know that, as Dr. Story mentioned, we can talk hours and hours about this technology. It's a very exciting one. It might be science fiction for some, but I believe that sooner or later that will be integrated, because as Dr. Armstrong mentioned, demography is cynic. We have aging of the population, sicker with chronic illness, and we don't have any choices to go with these assistive devices to integrate it to improve the quality of the care. Thank you all, amazing discussion, and looking forward to see you all next week. And Dr. Rashid, looking forward to have you as a former member of